Hello my viewers, welcome today to the topic of endocrinology. We're going to be going over Cushing's syndrome. Now before we start talking about Cushing's syndrome, we really need to understand the physiology of how Cushing's syndrome really exists, which is based on elevated amount of what? ACTH. But where does ACTH really come from? ACTH is actually under the influence of the CRH hormone, which is what? Corticotropin releasing hormone, which is CRH, made in the hypothalamus. When this hormone is made, it goes down into the anterior pituitary gland and tells it to make adrenocorticotropic hormone. Since the name says adrenal, which right? Adrenal, right? Cortico, right? Something related to what? Cortisol, tropic hormone. It's a hormone. Tropic means to attract, fall in love. Go to the adrenal gland and make cortisol. So what does this hormone do? It listens to its master. It's gonna go dun, 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 bam, right there, and activate the enzyme desmolase inside the adrenal cortex, which is gonna now convert cholesterol and follow this pathway all the way down here to make cortisol in the what? In the zona fasciculata, the second zone. Cortisol is also known as glucose, from glucose, corticoid. That's another name for cortisol. And it's very important that you pay attention, because that's one of the main reasons, not the main reason, but it's because it's involved in gluconeogenesis, the generation of new glucose molecules when you're stressed out. So, when does our body really make cortisol? Let's see. When I'm starving, when I go into starvation mode, the body activates stress hormone. It's usually when you're stressed, guys. Because our body really needs to be able to respond to stress. So the key hormones actually usually made is cortisol, growth hormone, norepinephrine. This hormone are required to generate energy producing molecules. What is the key and the most primary energy producing molecule in our body? Glucose. So cortisol is made in the adrenal gland, pumped into the circulation when you're stressed out, when you're starving. It's key important when you're sick, when your body's under infection, because your body's trying to keep up what? Metabolism. So all of a sudden, this guy actually goes and activates in the liver. And we'll talk about how we talked about it in the adrenal physiology lecture, but we mentioned in that lecture talking about how cortisol, when you're under stress, does what? Because it's called a glucocorticoid, right? It's a glucocorticoid. It's gonna convert oxaloacetate all the way back using phosphoenol pyruvate carboxylase enzyme to make what? Phosphoenol pyruvate, which is not going to reverse all the way back to form glucose. And now you just undergone gluconeogenesis. This is the molecular, the biochemical pathway that cortisol actually activates this enzyme to be made inside the nucleus, in the liver, in the hepatocytes, so they can crank up glucose into the circulation. So now this glucose can go to your muscles, can go to your heart, can go to the brain, right? So you can now keep moving, because if I see a snake, then I'm going to be stressed out. And when I'm stressed out, I'm not in a good mood, and my body's trying to get me out of that problem. And I need to run, and I need more glucose to burn. Are we on point? Good. So that is how cortisol is made. Now, what happens when cortisol goes out of whack? That is the point of this lecture. Hypercortisolism, which is known as Cushing's. Now, this pathway is a crazy pathway, which you need to memorize as a medical student. But I had talked about in the steroid pathway how we can make a shorter version of this pathway. And I want you to notice that ACTH goes all the way down to activate this pathway so we can make cortisol. Can you see that? Make aldosterone and also testosterone pathway. They're all included in the same pathway. But just for the interest of space, I want you to realize DHEA is up here. Androstenedione is up here, which is going to be aromatizing to estrone. Testosterone can be aromatizing to estradiol. And testosterone can be converted by 5-alpha reductase into its most potent form to form dihydrotestosterone. Just in the interest of space, we're going to erase just this part. And this is in the glomerulus reticularis. We just got rid of the reticularis, guys. And now let's talk about Cushing's. In our lectures, we always talk about definition. That is key. We need to define what we're talking about. What is Cushing's? Cushing's is just elevated amount of cortisol. It's too much cortisol that we need. Now, I need to remind you before we move on that when we make ACTH from the pituitary and we make a lot of cortisol in the glomerular zona fasciculata, when enough cortisol is being made, there's a feedback negative inhibition into the pituitary to tell it to stop making ACTH. There's always a negative feedback because our body is smart. We need homeostasis, right? So if I give you a cheesecake right now and you're eating it, at some point your body is going to tell you, stop chugging it down your throat. That's a feedback. That's enough. We're full. Come back next week. Cortisol has a negative feedback, which means it's going to decrease ACTH. And since ACTH is going to decrease, we're going to normalize the amount of cortisol we have in our body. That is normal physiology. Now, when there's too much cortisol in our body and everything kind of goes out of whack, the doctor's got to figure out where the cortisol is coming from. But before we talk about that, let's talk about Cushing's syndrome and Cushing's disease. You know, it used to take me a while because I memorized this and I can't figure it out. And I'm like, well, Cushing's disease, which was the syndrome. Until one day I thought about it in medicine. Syndromes, with an S, syndromes is a collection of items which are symptoms. So, let's think about a syndrome. Down syndrome. When you see somebody with Down syndrome, they have different pathologies going on with them. Their heart is not working right. They have this atrial septal defect. That's one defect, right? That's one symptom, right? They might have loss of, like maybe a single palmar crease. That's another thing we see. It's telling us, okay, it's a collection. So we have, you look at their chromosome abnormalities, and it's all these little things we put together, and it's called a syndromes. Perfect example: Plummer-Vinson syndrome. Okay, Plummer-Vinson syndrome is a combination of three things: glossitis, iron deficiency, anemia. 3, and they have esophageal webs. Esophageal webs. Now, all these three things, honestly, they're not related. They have glossitis, and you see also some colitis, that kind of little cut by the side of their mouth, of their lip. They have iron deficiency and anemia. And somebody said, look, all these three things, if you find it in a patient, you do a barium swallow, and you see a little web inside the esophagus, something like that, with a line. All those three things, we're going to call it a syndrome. So in medicine, we always take little things like that, we put it together, and we've always find a constant in a certain group of people. We name it a syndrome. The same thing goes with Cushing's syndrome. if you see somebody that has all the symptoms that we're going to talk about, you said, now they have a syndrome. The disease, we can actually tell you exactly where the disease is coming from, because there's something wrong in there, maybe in your brain, and especially the difference is in Cushing's disease. Cushing's disease, it's something in the pituitary. There's a pituitary adenoma that's actually producing too much ACTH, making you to crank up a lot of cortisol into your body. So that's the disease. That is where the problem is. And somebody once told me, ease is when you're at ease, right? Everything is fine. When something goes dysfunctionally and becomes dis-ease, right? A dysfunctional ease is a dis-ease. Because normally everybody wants to be at ease, but when somebody's stressing you out, you become diseased. Or something is wrong in your body where nothing is working right. So syndrome is completely different. We're going to talk about exactly what actually causes Cushing's syndrome. So what are the most common causes? Now we've defined, let's go to causes. The most common by far, guys, cause of Cushing's syndrome is us. Us, yeah. It's the doctor. It's iatrogenic. Everybody's on steroids. Everybody is on steroids. It's called iatrogenic Cushing's syndrome. That is by far iatrogenic Cushing's syndrome. Check this out. If you have COPD, you have to be on steroids, right? Because there's all that inflammation in your lungs, right? If you have asthma, we give you steroids. If you have sarcoid, we give you steroids. If you have dermatitis on your skin, we give you steroids. I mean, talk about any kind of inflammation in our body. If you have lupus, we give you steroids. Any autoimmune disease you can possibly think of, you're getting steroids. And these steroids, you're going to be taking them for the rest of your life, pretty much, sometimes. So this is serious, right? So if I'm giving you the steroids, which is basically giving you like cortisol-like drug, which is going to be in form of a steroid, right? Eventually you start to manifest syndromes of Cushing's because you've just been on the drug for so long, right? There's no difference of having an elevated amount of cortisol in our body or we're actually swallowing the pill ourselves. So a lot of people on prednisone, right? We give people prednisone all the time. Come with an asthma attack, you might get a prednisone. You come in with COPD, you might get a shot of prednisone when you get to the emergency department. Now, on the other hand, there are other ways you can also be making a lot of cortisol, and that could be what? An ACTH producing adenoma. Now, ACTH producing adenoma, we are basically in this case talking about that big little pituitary gland, right? That's cranking up a lot of ACTH, which is now going to the adrenal gland, right? Going up here and cranking up a lot of cortisol. It's a tumor. So that's completely different. Now that's a disease. Let's erase that and find out what other ways can we make cortisol. This is coming from the pituitary gland, right? Another way we can be making a lot of cortisol, it could be an adrenal gland itself, right? It's pretty straightforward. If it's not coming from your head, or if you're not taking the pill, it's coming from the pituitary gland, right? Cranking up a lot of ACTH, telling the adrenal, make more, make more, make more. Then adrenal gland can actually have an adrenal gland adenoma, which is just cranking up a lot of cortisol. So at this point, down at the back, on the adrenal gland, it doesn't care what ACTH says, they're just cranking up so much cortisol. Hello? Now, the last but not the least way you can actually be also cranking up cortisol can actually be now from an ectopic source. And it's usually an ACTH producing cancer. Perfect example we have is small cell carcinoma of the lung. You know, I'm going to be honest with you about something. Small cells, I just feel like some people, just the fact that they're small and they're short, they just want to make more problems. They make more trouble in the neighborhood. They want to have their voice heard, and if you're going to hear them out, they're going to cause more problems. So small cell, every time I think about small, I'm like, oh, that is some badness coming. Tall guys, they're already tall. They can see everything. They could kill it. But these small people, they're always jumping over everybody, stepping on everybody's toes. Just like small cell carcinoma inside the lung, start to crack up and make a lot of ACTH, telling like, you know what? Can you make a little bit of cortisol for me, please? Yeah, thank you very much. Can you make a little bit of cortisol for me, please? Thank you very much. And it keeps doing that every day. That is another way. And that's usually, you know, not as common, but definitely is something you got to keep track of. Now, another kind of, you know, cancer, again, carcinoid carcinoma can do that, and bronchial carcinoma, thymomas and bronchial carcinoma can do that. Not carcinoid, just bronchial carcinoma. So, a bronchial carcinoma or a thymoma. And thymoma is just a tumor of the thymus gland. So, now that we've known where the bad guys are and where they're producing a lot of ACTH or whatever, and just one key point I just need to mention before we forget. Why do they call it the adrenal gland? Because we have the kidneys, which is the renal, right? And something was added to it, like a little ice cream cone. Because it was added, they call it the adrenal gland. I thought that was a fun fact for you to know in between our lecture. Now that we know the causes of elevated amount of cortisol, we're going to have to go fishing. But before we go fishing, when the patients are going to show up in your office as an endocrinologist, you're going to have to figure out or suspect if they do really probably have Cushing's or not. That's our job, right? That's the job of physicians. We try to figure out what the problem is. Make this nice and clean. All right, perfect. So what are the patients going to present with? That's always the next phase. Symptoms. Now, we're going to have to break this down so we understand why patients are actually presenting with this. So we're going to start with number one. This is usually what our patients are going to look like. They're going to have central obesity. I mean, double donuts. So we're going to try, let me see if I can make a picture. This is just going to be a little picture of a patient that has Cushing's. All right. Let's try this. Let's draw this guy like that. All right, that doesn't work. All right, that's an exaggeration, but it does the job. Kind of look like the dude is pregnant. Actually, wow. I don't know if you've been walking around the beach a couple of times a week during this summertime. You might have run into a couple of these people. They do not look too happy, okay? There you go. Now, You're gonna have some little purple striae on their stomach. There you go. So they're gonna have central obesity. That's central obesity. They're gonna have a moon face. See how moon-like I drew the head? They're gonna have a moon-like faces. Moon-like faces. Okay? You're gonna see they're gonna have a buffalo hump. That is the buffalo hump in the back right there. Right intrascapular, right at their back, a little hump right in there. A buffalo hump. These are just clinical features. Just right as the patient walks into the door, you can see it. Round face, pot belly, centripetal obesity, a buffalo hump. You're going to see purple striae. See those purple striae? We're going to start explaining why these patients look like this. You know what? Since it's purple, why don't we just make that in purple too? Purple abdominal striae. Look at striations. Now, the reason why they have purple abdominal striae is because cortisol has effect on collagen, and it allows it to stretch. And that's why they actually have those purple abdominal striae. Because you see the, you can see the blood vessels right under the dermis, but because it thins out the collagen right on the abdomen, so you can see actually the abdominal girth. Now, they also have easy bruising because the collagen is not well formed. Easy bruising on the skin in their body. Now let's talk about the other complications of having too much cortisol. And that's where all the bread and butter of how cortisol causes a lot of problems are going to come for you. But these are the common things you're going to see this on this patient. You're going to also see really skinny hands, muscle loss in extremities. Now, the reason why they have muscle, see how thin these guys' arms are, is because of cortisol causes muscle breakdown. If you look at the lecture that we talked about initially in adrenal physiology, we said what the cortisol do? They break down proteolysis. That's the protein in the muscle. So that's why they have really, really skinny hands. They have a lot of skinny legs. Skinny legs, skinny arms, pot belly, because they have a lot of deposition of abdominal fat. Now, this abdominal fat also predispose people to what? Diabetes, because we know people with huge big pot belly, right? It's also a predisposition, but these patients actually have glucose intolerance. Now, why do they have glucose intolerance? Let's think about it. We talked about what is the function of cortisol. Cortisol is a glucocorticoid. A glucocorticoid is going to be cranking up what? Glucose. Undergoing gluconeogenesis. We talk about that oxaloacetate being converted back into the pyruvate, phosphoenol pyruvate, going back all the way into the glycolysis pathway. The gluconeogenesis pathway, the reverse of glycolysis, to crank out glucose. So if you're cranking so much glucose, what will happen? Eventually your insulin production is going to be maxed out, because now the pancreas has to constantly work and predispose you to what? Tell me. I know you know it. Tell Papa. Diabetes. So these patients are predisposed to having diabetes. You think the show is over? That's called decreased glucose intolerance. Now, another problem with having hypercortisolism is what? Masculinization in females. Why do the women get masculine faces? Remember, this pathway, I told you, if you're making too much ACTH, this pathway is going to be cranking up a lot of what? Androgens. Remember, there was DHEA right in here before this androstenedione, and eventually you make testosterone. Because women have too much testosterone, what will happen, cranking up from the adrenals, they become masculine. Masculinization in females. I don't think males can get more masculine than this, right? Because What happened? They have deep voice. If they don't have a deep voice, they start to have what? Facial hair. That's called hirsutism. Right? We can call that 8A. Are you surprised? This is not a girl, but you know what? We'll give you a little bit of goatee. Like being a female, but hirsutism. Because of the androgen production. Remember, they're all up on this side, cranking up all those androgens. What also happens if you have more testosterone than estrogen? They become oligomenorrhea. Or amenorrheic, which simply is a fancy word for women that can't have menstruation. You don't have your period. This is serious, don't you think? Look at all this thing that's going on. Now, you would think it's over. Let's check their bones. If you thought they lost muscle, this is what their bones are going to look like. They're very frail bones because they're predisposed to what? Osteoporosis. Osteoporosis. Because the reason why they develop osteoporosis is because the bones start to break down. That's the effect of cortisol on bone. You start to break down your bone, and these patients can actually get fracture. Even worse is a vascular necrosis of the femoral head. The head of the femur actually, and that's usually very common in patients that are on chronic steroid. The head of the femur right here gets decreased in blood supply to it, and it gets necrosed, and you can get fractured the hip, and you wonder, oh my God, why is like a 45-year-old female fracturing her hip? Because she's been on steroids for so long, and that will cause decreased blood flow to the hip, and eventually the femoral head is gonna almost fall off and crack. Now, worse come to worse, when you think having hypercortisolism or Cushing's syndrome is bad, wait till you see how this patient, if you have all the symptoms, what do you think how these patients are gonna feel? Just even without thinking about it. If somebody has a round face, pot belly, skinny hand, walking around with striations on their abdomen, they got a hump, I bet you they don't feel good, right? No, because they're gonna be depressed. That's another side effect. Depression. Well, I'm not going to be surprised if you have all this. And plus, they haven't seen their period in days. Whoa. Okay, a young, cute little girl that's not got a period and she's not pregnant. You know what I'm saying? This is serious. Just because they either have Cushing's syndrome or they have the disease. So this is serious, guys. You won't want anyone to look like it, but we got a lot of people walking around like that in America, right? So, or they can go manic. All right, so those are one of the biggest things. And overall, to top all of this, after the guy or the girl is depressed, they become immunosuppressed. Do you like that rhyme? You would think somebody who has Cushing's syndrome is depressed. Wait till you see that when they become immunosuppressed. Why are they immunosuppressed? Because it's all about the whys, guys. Immunosuppressed. I told you, inside your blood vessels, right? Neutrophils like to float around to go take care of business, right? There's just a bacteria in the building. It's going there and kill them. I'm not going to go into the crazy pathway of how neutrophilic infiltration destroys bacteria through the NADPH oxidase pathway. But when you're on steroids, your neutrophils become inactive. Literally, they can't really migrate. And the way I think about it, I feel like the neutrophils are actually blinded, and they kind of wrap something around. The steroids kind of wrap around their head. They're all loopy also. They're like, oh my God, right? So they don't even know. So you get leukocytosis. So if you see somebody has a white count, leukocytosis, high white count, like your white count is like, 12. It's always 12. They're not sick. They're fine. Maybe they're just on steroids. If they're on steroids for so long, you're going to expect them to have what? A reactive leukocytosis, just because all the blood vessels are open, right? And the little neutrophils are just kind of floating around. They're getting detached away from the endothelial cells. And they're just like, yeah, we got nothing to do. I heard you're sick, but I don't know. So that's a problem, right? Because when you're stressed out, You're not going to be able to fight infections. Not cool. Not cool, guys. So neutrophils are not going to be working, and that's going to make you immunosuppressed. That's called impaired immunity, guys. Now, that's enough to talk about somebody's clinical features of Cushing's syndrome. Now, do you see why all these little things come together to we call it a syndrome? But occasionally, it might be coming from the pituitary adenoma, which means then it's a disease. I don't like the look of this girl, so we're gonna have to get rid of him, okay? Okay, there you go. Sorry. All right, now, when somebody walks into your office, right, or in the hospital, whatever, and you see that, and you're like, you know what? It's a couple of things, right? So let's do a case, because we're gonna have to figure out what's wrong with this patient. Let's do a case. A 22-year-old female has Cushingoid appearance. Basically, I just summarized all that stuff those 10 things I just talked about. Oh, I forgot to tell you. Okay, I'll put it in. Cushingoid appearance. We took her vital signs, right? She's 22 years old, and her blood pressure was 148/90. Okay? Her blood sugar, a random blood sugar, was 250 milligrams per deciliter. You suspect that this patient might have Cushing's, and you want to make the diagnosis, but I want you to explain to me, why is their blood pressure elevated and why is their blood sugar elevated? You can tell me now why their blood sugar is elevated, right? Because we said it's a gluconeogenic hormone, it's cortisol, so definitely they're cranking up a lot of glucose. So okay, that's fine, I get that, I get it. Why is their blood pressure elevated? Why does this patient have elevated blood pressure? If you look at the pathway for the phenylalanine pathway, I'm just going to shorten it in the interest of time. Eventually, you know, your adrenal gland, right, in the adrenal medulla, we're going to be making epinephrine, right? Yeah, epinephrine. Now, epinephrine is actually converted into norepinephrine under the influence of what? Cortisol. Now, I wasn't going to mention the name of his enzyme, but people just want to know so much. Some people just want to know more than others. PNMT stands for phenylethylamine methyl-O-transferase enzyme. Does anybody care? I don't. The part of the lecture is cortisol is involved in activating and converting epinephrine into norepinephrine inside of what? Inside the adrenal medulla. So, what does that mean? If I'm constantly making so much norepinephrine, what is norepinephrine going to do? It's going to go, right? Here's my cute looking hearty, right? Into the kidneys. What is it going to do? Vasoconstrict my venous drainage back into the heart, increasing preload. It's going to what? Increase my contractility, right? It's going to bind to all the what? Alpha-1 and beta-1 receptors. It's going to also increase my afterload, increasing my cardiac output, increasing my what? Since we cardiac output times stroke volume, your cardiac, increasing your heart rate times stroke volume to increase your cardiac output, which is going to form your what? Your blood pressure, right? Because norepinephrine is constantly doing what? Making your heart contract real fast, vasoconstricting all the arteries and the venues, and now your blood pressure is high and you're so young. So young. All because cortisol went out of whack. It's only supposed to work when you're stressed, because when we're stressed, our heart rate goes up, right? It makes sense. I see a little snaky, I'm like, oh God, I'm not going to be like, hey honey, It's just a rattlesnake. Let me no, you're gonna run for your life. Okay? So now let's make the diagnosis. All right? Let's diagnose this patient. So the way we're gonna diagnose this patient is this. Diagnosing Cushing's. Diagnose. You know what? Just gonna put diagnosis right there. The first thing you want to do for this patient is to do an overnight, 1 milligram low dose dexamethasone, which is actually a very potent steroid, test around 11 p.m. at night. Okay? Now these patients, give them 1 milligram of dexamethasone at 11 p.m. And in the morning, you want to measure their cortisol level. Now, physiologically, let's talk about this. If I give you a healthy guy, if I take dexamethasone, which is a low-dose steroid, it's a low-dose steroid. If I take it, what it will do is, because I'm adding it to the cortisol it's already in my body, it's going to go and inhibit ACTH production inside my what? Pituitary. So that's what it will do, right? So dexamethasone normally will do this. It will go and inhibit ACTH production inside the pituitary gland so that my cortisol level should be normal. It should be out of whack. So if that is normal, I don't have Cushing's, right? Because I just gave you a low dose steroids, and lo and behold, the cortisol level is normal. Or you can also do a 24-hour urine cortisol level. Because if you're cranking out this cortisol, it's going to have to go through your kidneys at some point, and you can actually detect it in the urine. So if it's very high, we've got a problem. So that's the first initial test we always do. Overnight, 1 milligram dexamethasone. If it's normal, forget it. You don't have Cushing's, you're fat. Sorry. Yeah, I didn't mean to say it like that. You're a little bit on the chubby side. Maybe you should go to the gym and work out a little bit. All right? I think that's what you need. Diet and exercise. But if it's abnormal, so let's start with this. So an abnormal, normal. So we did 1 milligram DMX, test, and it came out to be abnormal, which means your cortisol level is high. Now, before I start going nuts about this, I want to draw on this side of the board. I got a better pen here. I want to draw the brain. Just need some space. I'm going to draw the brain here. Okay, the hypothalamus. This is my own little cute version of the brain, okay? Don't mind it. It works, okay? That's the brain. And we know in the hypothalamus we make CRH, which is going to feed down to give us ACTH. Here I'm going to draw the kidneys with the adrenal gland, because this ACTH is going to come to the adrenal gland and give us some cortisol. Right in here, we're going to put in a little cutie longin in there, okay? A little long, because we might need him eventually, okay? Because I want you to be able to follow what I'm doing to see when I tell you something's too high or something's too low, it can all make sense. Alright? So, the next step you want to do is, since cortisol level is high, right? Abnormal, right? High cortisol. The question is, where's the cortisol coming from? is it coming from the adrenal gland, or is because something in the pituitary is making it happen, or something from the lungs like a cancer? Obviously, we already ruled that this patient is not taking any steroid. Okay, so she's not on steroids. So we knew it was high cortisol. So what you want to do next is do a high dose dexamethasone test, suppression test. The reason why they call it dexamethasone suppression test is because if I give you now a high dose, let's bring in a high dose DMX. That's a big dose, okay? That's the pill right there. If I give it to you, what should it do? If it suppresses, if your cortisol level, all of a sudden now, let's check the cortisol level. If your cortisol level drops, low cortisol level, why would that happen? The only way your cortisol level can drop is if you have a pituitary adenoma. That means high dose is strong enough, and it's always strong enough to inhibit ACTH production. But, actually, I'm sorry, before we jump to high dose suppression test, we had skipped one simple step. If your cortisol level is high, let's check your what? ACTH. So that's the next step. Let's check what the ACTH level is. If your ACTH level is very high, tell me exactly, that's exactly the next step. I'm very sorry for that confusion. If this ACTH level is high, it has to either come from two spots, right? There's only two spots that can produce ACTH, the lungs or the pituitary gland, lungs or pituitary gland. So we know we have two differential. It can be a pituitary adenoma or a small cell carcinoma if ACTH is very high. Are you with me? Good. Now if ACTH is low, if your ACTH is actually low, well, it's two things. It can only come from what? The adrenal gland, because the adrenal gland is cracking up so much cortisol that it's causing a negative feedback into the brain, which means your ACTH has to what? Actually drop. That's why ACTH is low. So it definitely has to be coming from what? The adrenal gland. Now, that's good news. Now, let's say your ACTH is low. How can I know you have an adrenal gland adenoma, right? Tumor. The only way I can detect that, the next imaging study I have to do is do a CT scan of your abdomen. And guess what I'm going to find? If I find that little something in there, that is where the answer is. You have an adrenal gland adenoma. And we'll talk about what we're going to have to do about that. If your ACTH, however, is very high, the next step now to differentiate between these two is to give you that high dose dexamethasone. If I give you a high dose, really super high, you chunk it down, what we'll do is it's going to go back and inhibit what? This is the DMX. It's going to go back and inhibit ACTH production if it's an adrenal adenoma. It always responds to high dose. All of a sudden, if your cortisol level drops and your ACTH level drops, just told me the answer. ACTH level is low now because I just gave you a high dose. We just nailed the diagnosis. You have a pituitary adenoma. However, if it's coming from the lungs right in here, because it doesn't care. I told you small people are nasty. They could care less what's going on in the world. They just want to make noise. It's not going to respond to a high dose steroid. It's only the pituitary guy is going to respond. In the lungs, my guy's just maintaining his ventilation, just chilling in there causing problems. You just know the diagnosis of somebody possibly having squamous cell carcinoma of the lung. But how are we going to be able to know that? Why don't we do a CT of their chest to be able to find it? Or you can also do an X-ray But the best and the most accurate to actually know it's a squamous cell. If you find something on the CAT scan, and you're like, wait a minute, you got something on CAT scan, and you go in there and you take a biopsy, you do a bronchoscopy and you take a biopsy, and you see it's a small, it's a small cell carcinoma of the lung. How are we gonna be able to diagnose pituitary adenoma? You have to do an MRI. That is the best and the most accurate way to be able to see it. But always remember, see how it went through biochemical tests first, using high dose steroids, checking for cortisol, ACTH levels, and that's how endocrinologists work. Okay, we do biochemistry first, and then we go for what? We go for the imaging. Don't go for imaging first because you don't know what you're looking for. That's what's interesting about endocrinology. So on MRI, I see a big tumor. I'm like, you've got a pituitary adenoma. If I do a CAT scan of your abdomen, you have an adrenal adenoma, or we do a CT chest, we are going to find a small cell carcinoma. Usually this patient is a smoker, has been smoking for years, and guess what? I forgot to tell you. After a while, we're like, oh, in your social history, do you smoke? You haven't been smoking for the last 15 years. Well, she's 22. She's been smoking for, let's say, since she was 12. Well, 10 years. I just made that up. But now that we know the answer, we got to treat, right? We now know how to make the diagnosis. Let's treat this patient. We're not going to be like, guess what? We just figured out what's wrong with you. Oh, you could go home now. We're just not going to do anything about it. No, we're going to do something about it. So we say there's 4 causes, right? The first cause is iatrogenic. Treatment. The first cause is what? Iatrogenic. If it's iatrogenic, since I'm the one giving you the steroid, we're going to have to taper you down. Slowly. You're just not going to stop them abruptly, because if you stop somebody who's on steroid abruptly, what do you think you just did? When you give somebody prednisone for so long, right? They've been on steroid for so long because they have lupus, and you're like, oh, now your lupus is kind of good. Let's kind of get. If you stop it abruptly, they can die. You know why? Because now prednisone has shut down ACTH, and their cortisol level is so low, it's almost undetectable. Guess what happens to the adrenal gland? It shrunk. It atrophies. So if you stop this prednisone, number one, they're immunosuppressive. If they get sick, they can't mount an immune response. And the bacteria can just walk into the block and kill the patient. You don't want to do that, right? They can't mount a stress response because when they're starving, they can't mount their blood sugar. They can pass out in a coma if they don't have sugar around when they're stressed. So that's a bad. So you taper them down literally. It's literally, if there's, you kind of taper them all the way down. Let's say they're already at 40 milligrams of dexamethasone or prednisone. You taper it down weekly, eventually to 10 onto 0. And then by that tapering it down, the body actually realizes, okay, we don't have enough cortisol. Now we got to activate ACTH back up again and start to crank up cortisol. Now, there's something about patients that have iatrogenic induced Cushing's syndrome. They never have hyperpigmentation because you're giving them the steroid. So always note that's something I forgot to tell you. They will not have hyperpigmentation. However, if patients actually have Cushing's disease, a pituitary adenoma, if a patient has a pituitary adenoma, well, how are we going to treat it? Well, before we treat it, something interesting is that they do produce a hormone called POMC, pro-opiomelanocorticotropin, which is actually causes them to have hyperpigmentation. It's usually when CRH comes down to try to activate, to make ACTH. POMC is actually made in the process, and these patients actually do have hyperpigmentation on the skin. Okay? So if you have a pituitary adenoma, there's 2 ways. Remember, before we start cutting you and taking, nobody wants to do surgery, right? I don't want to go to surgery. Don't take me out. Don't cut me. So there's always a medical treatment, right? So the medical treatment for this is you can actually give give them ketoconazole, or methylpyrrone. See if it works. And how ketoconazole works is right here. Ketoconazole actually goes in there and inhibit desmolase. Or you can give them methylpyrrone, which is an enzyme that's going to cut off this pathway. But usually we don't do this because typically we always do medical first treatment. But since it's an adenoma, it's better to just do a transsphenoidal resection of the tumor, because that's what's best for the patient. Now, if we can't get in there to take out the tumor, then we can have to give you this tool. We can give you ketoconazole, which is an antifungal, but it actually works to inhibit cholesterol breakdown by inhibiting desmolase. So now you can make cortisol, and also we can give you methylpyrrone to inhibit 11-beta hydroxylate pathway to make cortisol. Now, there's one key thing I forgot to tell you about why these patients also have hypertension is because cortisol has an aldosterone-like activity, mineralocorticoid-like activity. So you're indirectly also kind of it's acting as aldosterone, so now you're also retaining sodium and water and also increasing your blood pressure, aside from converting epinephrine into norepinephrine. So that's another key point why these patients have high blood pressure. So, transsphenoidal resection. If it's, we've done pituitary, we've done iatrogenic. If it's an adrenal tumor, we're going to go in and do surgery to resect it. Okay? And the fourth, if it's a small cell carcinoma of the lung, because small cell carcinoma are very hard to resect, they're going to have to go undergo radiation therapy, and that's pretty much the only way we can fix that, because small cells are so small we can't even get to them. They're little oat cells carcinoma. Okay? One thing I want you to also remember is patients that have pituitary adenomas that's cranking up a lot of ACTH, they're going to have adrenal hyperplasia, which is causing them to make a lot of cortisol. And that brings us to the end of this beautiful lecture called Cushing's. And now today, you can now go out into the real world and actually sit back on the beach and say, man, I think that person might have Cushing's, but I'm not sure. You know what? Don't do that. It's for medical information, and it's great that you know this so you can help your patients. That's the whole point. All right? Now we understand how Cushing's is formed. In summary, like we always do, Cushing's is due to elevated amount of cortisol. It can come from 4 ways. You're taking the pill, which is taking prednisone, or taking any kind of steroid. It can be pituitary adenoma. It can be making from the adrenal tumor, which is an adrenal adenoma. And it could be coming from what? A small cell carcinoma. These patients have Cushingoid appearance. Chalky face, chalky belly, purple striae in the abdomen, buffalo hump, they're hypertensive, osteoporosis, they can get fractures. These patients are depressed and they are also immunosuppressed. Are you feeling me? I'm trying to rhyme. And also we have to diagnose this by going through all that work up to make the diagnosis. And once we find the location, we take a picture using a CAT scan, MRI of the brain, a CAT scan of the chest or the belly, and then we go in there and cut it out. If we don't cut it out, we might give you medication. And that is the end of our lecture. I hope you enjoyed. I'll see you again soon. Take it easy. Have a great day. Bye-bye.